Moving on to the next session. To chair the session on the topic nutrition in hemodialysis patients, common pitfalls, I'd like to invite Dr. Vikrant Reddy sir, Senior Consultant Nephrologist and Transplant Physician, Care Hospital, Banjara Hills, Hyderabad, and Dr. Vijay Chandar sir, Assistant Professor at NIMS, MRCP, ECNF, then Dr. Prashant Kumar Dikshit sir, Classified Specialist and Nephrologist, Command Hospital, Air Force, Bengaluru.
So the speaker for the next topic is Sunitha Premalatha, who is AGM Chief Dietitian, currently working at Yashoda Hospitals, Hyderabad. And I request Madam to take over from here.
Ma'am would be discussing about nutritional pitfalls in hemodialysis, an observational study.
Thank you. Good evening, everyone. I thank the organizing committee for having me here as a speaker for this wonderful conference. And talking about my talk, it's actually about nutrition in hemodialysis, common pitfalls. When we look at end-stage kidney disease, hemodialysis patients, I know it is a global health burden. And what we observe in these patients is their poor survival rate compared to the general population. And even though, despite we have better dialysis technique, better infection control, better vascular access, still the mortality rates are high and they're unacceptable. Now, when we look at these patients, what we need to identify is simple, easy, widely acceptable biomarkers that can predict their survival, which are very, very important coming to nephrology or for that matter renal nutrition. So these biomarkers can be used for risk stratification and also they can guide for individualized nutritional management of these patients. I know that dialysis keeps these patients alive, but nutrition determines how well they live. And in this patient population, as a dietitian, what's more important and the danger is not about what they are eating. The danger is about what they stop eating once they are on dialysis. And yes, there is declining muscle mass, muscle function, and there's so much of confusion. Almost every speaker talked about what are the, social media is loaded with a lot of misinformation, misleading information. And behind every normal lab report, so-called normal-looking patient, there is a declining muscle mass, there is a declining muscle strength, and of course, poor survival. So today I'm going to talk about those common pitfalls that are commonly seen in patients on hemodialysis. I'm sure everybody sitting in this hall is all aware of those guidelines. So I didn't want to talk about any one of those, like KDIGO or KDOKI guidelines for that matter, or National Kidney Foundation or ASPEN or ISPEN guidelines. We are well versed with that. We all know what is important for our patients, what we need to limit, and what we have to balance overall in order to lead optimal health. There is a gap that is between the recommendations and practical application of these guidelines. So to explore that gap, what we have done is, we have done a simple observational study with 75 patients, because our hospital is a small setup, and actually what are these pitfalls from the patient perspective? Not what the guidelines say, but let's hear from the patient perspective, what exactly are these common pitfalls and how we can prevent. So it's a small sample size of 75 patients, observational study, which has about a structured interview schedule. And we have collected the data, and I'm going to present that data. If you see that the age, the mean is about 54 years, predominantly male patients, and of course, yes, most of them with CKD have hypertension and a combination of diabetes and hypertension. And if you look at, we had more number in this study with who are on dialysis less than 1 year. First is BMI is misleading. It talks about your body weight, but doesn't talk about your nutritional status. Why I say BMI is misleading? There could be fluid shifts, fluid overload. It can mask sarcopenia, and BMI should not be single predictor. You should go beyond BMI and do body composition and grip strength. I think every dialysis center at least should have a hand grip dynamometer. So we should go beyond what is BMI. And then it reflects just weight. And if you look at the Kaplan-Meier survival graph, I mean, most of the studies, we all know about the obesity paradox, which talks about higher your BMI, better is the survival rate. But BMI alone should not be, it can be misleading. You can combine with body composition, hand grip strength, or lab parameters. Coming to simple anthropometric measurements, I think these are simple, quick, inexpensive, especially in a low-cost setting where the technicians also can be trained to perform few of these anthropometric measurements which are valuable. And to begin with, first is tricep skin fold. It is a surrogate marker for your subcutaneous fat. It gives you the average thickness of that. And there are many studies which indicate that it is mostly associated with survival, hospitalization risk. As your tricep level improves, fat mass improves, there is better survival and decreased hospitalization risk. And also, triceps especially is a valuable tool in such patients because it helps in better risk stratifying them nutritional point of view. That is number one. And also, it will tell you about the nutrition changes, the trends in nutritional status changes. So for two important reasons, triceps skin fold is a very simple, easy tool which talks about your energy source. Then we have done the mid-upper arm circumference, which is a surrogate marker for muscle mass. All you need is a flexible tape. And yes, if you look at the value, overall they have adequate muscle mass in this. And if you look at the whole group, some of them are at high risk of muscle decline, undernutrition. And most important, again, mid-upper arm circumference is a very simple one. It can be done to detect protein energy wasting in these patients, and it is more informative than compared to BMI. And yes, it is affected by fluid shifts, but again, there is a strong association between mortality rate and mid-upper arm circumference. So as your muscle mass improves, survival rate also improves. Then coming to, if you look at the recent studies from 23 to 2026, calf circumference has emerged as a new anthropometric measure, which is very good at detecting sarcopenia in these patients. So it detects sarcopenia, predicts mortality. It's a strong prognostic factor, if you see, predicts mortality, functional decline, and also assesses, as I said, it's a prognostic factor, predicts falls, frailty, and muscle decline. And when you look at triceps, it gives you fat mass. Mid-upper arm gives you a combination of fat and muscle mass. But if you look at calf circumference, it is the lower limb bulk, which exclusively gives you, and it doesn't get altered with the fluid shifts. Coming to the last one, hand grip strength. I mean, most of them earlier talked about grip strength. Again, if you look at the grip strength, majority of the patients on hemodialysis have low grip strength, reduced muscle strength, which is the single most measure for muscle function. So a declining grip strength, which majority of them have shown, it is also a strong predictor associated with mortality and sarcopenia, protein energy wasting, and of course, specifically hand grip strength and quality of life are strongly related. Coming to the lab data serum albumin, in a critically care population, we don't look at serum albumin as a nutritional marker, but when it comes to end-stage renal disease, patients on hemodialysis, it's a very important. And not many hospitals actually regularly repeat serum albumin level. And serum albumin, if you look at most of the study population had low average albumin, which is a clear indication of protein energy wasting. 40% of the sample had hypoalbuminemia. Serum albumin is by far the strongest predictor of survival in dialysis patients, and a nutritional intervention that can increase serum albumin as low as 0.2 grams have immense impact on improving the survival of these patients. So how many of us actually, repeat serum albumin as per the hospital protocol. It is a very, very important because normal level of serum albumin correlates with better survival. And hypoalbuminemia is associated with poor survival. When we looked at the Pearson correlation, albumin versus BMI, there is an inverse correlation. Higher the BMI, there is a positive correlation. Higher the BMI, better is the albumin. Likewise, higher protein intake, obviously better serum albumin has been found. Now, do you think that even in low-cost settings, you can go for very less cost, inexpensive, bedside, simple, quick assessment tools where the technicians can be trained? And remember, should not be just one measure that you can go by. It should always be a cumulative it should be an integrated approach. That's what our study also, which we have conducted few years back, tells us that it should be a combination of different things. You can combine the lab parameters, also the dietary assessment, body mass index, and of course you can also, if you have a body composition, could be an added advantage along with anthropometric measures, so that you can accurately and early detection of protein energy wasting can be done and early nutrition intervention can start. And of course, how many of the hospitals are using the validated? We have the modified SGA, we have DMS or 7-point SGA nutritional scores, or more specific for the dialysis population is MIS. So that can be introduced into the dialysis units. When we look at the dietary intake, I come from a corporate hospital. If you look at the dietary intake, we talk about 30 kilocalories, and they hardly, it's very, very low comparatively, around 1200 to 1300 calories the calorie intake, and protein intake is also very low. We talk about 1.2 to 1.3, but if you look at it, it is not even 0.8. So 35 grams that is the mean. If you look at the mean value, it is very, very low. So protein deficiency is very common, and we talked about vegetarian culture, we talked about plant-based diets, we talked about the financial constraints, and most important, self-imposed restrictions. These are important, which have to be addressed. There was a dialysis patient when I was counseling, he said, "Ma'am, I want to record because my family members think that if I eat protein, my creatinine will increase, my other lab values will increase." So awareness and education is very, very important. The danger is they stop eating what they should. And sarcopenia and reduced quality of life are common in these patients because of low albumin and low protein intake. When we have actually looked at, we had a debate about plant and animal. I think the mixed approach is always good. Plant-based, I just want to clarify, doesn't mean no animal food. Plant-based is predominantly plant, but definitely also includes some amount of animal protein. So the recent guidelines say it should be a mix so that you get the best of it. And if you look at the food frequency, it is so sad that daily only few people eat egg. About only 34% of the population eat egg, and barely dal and milk and curd. Non-veg is just twice a week. And if you look at paneer or cheese or soya, not so much. And rarely, of course, they're not eating more of, we talked about phosphorus. From the packaged foods, they don't take so much of the processed foods. But yes, they're definitely eating very, very low amount of protein, which is so evident from their food frequency. And non-veg is also just once or twice a week. Coming to the appetite scores, yes, most of them, they have fairly good appetite. Especially patients say that post-dialysis they feel hungry. That is the time where they actually have to be fed with a good nutritious diet. And of course, small percentage say that they have decreased appetite. So when we come to appetite, how do we manage as a dietitian? Nutritional intervention, psychological support. Depression could be one of the main reasons for low appetite. Another common thing that we see is GI symptoms. They have bloating, they have early satiety, they have nausea, vomiting. If the symptom control can improve their appetite. And talking about majority of them, though they are, most of the patients complain about generalized weakness. We know dialysis itself is a catabolic process where they lose about 6 to 12 grams of amino acids. They feel very weak. And physical activity, we talked about so many structured, we talked about balance exercise, aerobic, with strength training. Are we doing it in our dialysis? We heard about cycles being introduced, but most of these patients are sedentary and inactive. So I don't know how many physiotherapists really enter into the dialysis center. So having a structured, simple program on exercise, whether interdialectic or intradialectic, can improve their muscle mass and quality of life. So having that is going to be important. Physical exercise and education about the importance of education and how it can improve the clinical outcomes, the number of studies about physical activity among these. But it does not meet the recommendations, especially when it comes to physical activity. Talking about the most important aspect, none of the dialysis center, even during the World Kidney Day, we have done a one-day survey. Most of the dialysis centers don't have a designated dietitian, in-house dietitian. So again, there is poor dietary compliance, there is more protein energy wasting, increased hospitalization, and high mortality risk. So awareness on diet, you can be surprised, 70% said we are all aware of the diet. Who is giving the diet information? They only get through the nephrologist. But to be very frank, there are very, very few referrals coming from a nephrologist to a dietitian. They still think that, we give some confusing advice. No, we have very good clarity, and I request most of the nephrologists who are talking so much about diet should also make sure that they refer their patients to the experts to take care, so that they are well informed. And dietitian availability, most of them are OP centers, so there's no availability of the dietitian. And also, usage of oral nutrition supplement is also very, very less. I know people talk about financial burden, but again, a person developing sarcopenia, not eating, low appetite, wherever intervention is required, we should be a little proactive. Nutritional intervention with high protein supplements, of course, renal formulas are a low phosphorus, low sodium, calorie dense, may improve outcomes. So there is enough evidence to show that these oral nutrition supplements improve outcomes, and giving protein-rich food or oral nutrition supplements during dialysis or on dialysis-free days is safe and has been associated with good outcomes. So better dietary compliance, improved lab markers, improved quality of life is seen in patients, especially 1 or 2 studies from Pune have been done, when they were better aware and they have better access to the dietitian. So when I have been given this particular topic, I would like to thank specifically Zamrud on this. I really liked it about the nutrition pitfall. So what I did is, when we have done this small observational study, we can develop our own nutritional pitfall score, and you can have it to your individual dialysis centers. So from the study that I have done with 75 patients, what could be the domains if you have to have a nutrition pitfall score to prevent them from falling into that? So one is inadequate protein intake and fluid balance, intradialectic weight gain, of course that's already easily available, asking them about physical inactivity, appetite score, mid-upper arm circumference, which can be easily done, and about their knowledge and dietitian accessibility. Probably we can give scoring to each thing. And when we compared with the study, most of them fall into the moderate risk, that is nutrition pitfall score, moderate in our study population. This score covers major dialysis nutrition pitfalls. It has a combination of diet, nutrition awareness, education, and of course clinical factors, so that it is more holistic and simple, and it can be used in OPD. So all I just want to summarize and conclude that protein energy wasting is not a single event. It is a cumulative many nutrition pitfalls that our patients experience. Less protein intake, over restriction of potassium and phosphorus, and of course there's so many other things, and that's what the danger is, not what they eat, what they stop eating. And that is why the malnutrition silently develops, and when it is clinically evident, it cannot be much reversed. So malnutrition is not inevitable, it is preventable, it is modifiable, and with early detection. So all I just wanted to tell that our goal is not just to treat malnutrition, but to prevent it before it actually begins. That should be our goal. Thank you so much for your patient listening. Thank you.